So welcome to Nottinghamshire Alliance Training Hub talk on growing older with HIV. So my name's Sarah Partridge. I work for Nottinghamshire Alliance Training Hub, and today we are delighted to have Dr. Ashini Fox, who's the clinical lead at Nottingham University Hospitals, to help us with the growing population and the ones that are growing older with HIV and sharing the gems of knowledge that she has. So I'm going to hand over to her and let her introduce herself. And thank you so much for coming today.
Well, thank you very much for inviting me, Sarah. So yes, I'm Ashini Fox. I've been a consultant at NUH for 15 years, and I'm the current HIV clinical lead.
I wasn't wrong.
I think what I was going, oh, does this do, are my slides moving? Yes, they are, brilliant. So I think the usual talk you get from HIV physicians is usually about, opportunistic infections and about, lots of sort of sick patients. And I thought it would be really nice, or alternatively, it's about testing. And I thought alternatively this time I'll talk to you about, some of the challenges that we actually experience in our HIV clinic, which is the outcome of successful treatment, really, because we have a cohort of people who are now growing older with HIV. So this is a really great thing. But as with a lot of great things, there are some additional complications. And this is particularly an area that I think is really important in terms of the interface with primary care, because a lot of the things that we are going to be, corresponding with you about are because of this aging population. So I'm going to tell you a little bit about epidemiology, because every good HIV talk starts with a graph, of course. But I will focus on cardiovascular disease, bone health, and the menopause, touch very, very briefly on cognitive function, mental health, renal disease, and oncology, and then end with polypharmacy. And if there is time, I am also going to go completely left field and just give you an update on the emergency department opt-out testing program at NUH, because I think that's something that's really important for primary care to know about. Now, do bear with me. Each of these areas is a whole talk in its own right. So I'm literally going to do some very sort of brief summaries, a kind of what I think you need to know in a few minutes on each of these. If you have any questions, please ask. I think we're a very small group, so you should feel free to ask anything you like. I will hopefully have some time at the end. And if you have questions about HIV that are not related to growing older with HIV, that's also fine. You've got me here for an hour. Use me as best as you can, or according to your needs. So, what's going on here? Let's see. When you see my slides, can you see the bar with the people as well? Shall I remove that? Is that annoying you?
No, I think we just see your slides.
You just see the slides. That's fine. Great. Okay, so this is the first graph, of course, looking at, this is the 2024 data, the latest data we have about new diagnoses, HIV new diagnoses in England. And you'll see that we were doing really, really well for a number of years. The numbers of new diagnoses, HIV diagnoses, were on a very distinct, definite decline. But since COVID, the numbers have been going up again. Now, part of that is the artificial drop related to COVID and people not testing during that time period where things were in lockdown. But some of this is also a real increase, which we think is a combination of more widespread ED opt-out testing, as well as the care workers visa, because we've had a lot of new entrants who are already known to have HIV on antiretrovirals, doing well, but moving to the UK. So we've had a real upsurge in the numbers of people living with HIV in England. And a lot of that is actually not in the big urban areas. It's in places like Nottingham, where we've had twice as many new diagnoses, for example, in 2024 compared to 2021, 2022. So this is important because it means that there is this additional strain on services, but at the same time, it's important to know that who we've got in our cohort is also changing. So you can see there the blue and the dark blue, that represents people over the age of 50. And you can see that this is kind of old data really going up to 2015. The proportion of people in our cohorts across England who are over the age of 50 has been rising. And that's great because that means longer with HIV. We've now reached a stage where there are more people over the age of 50 in our HIV cohort in England than there is people younger than 50. So it's literally overtaken. And so we have had to learn to become better at managing some of the conditions that you see as people age. What's also important is that people are aging, but they may not be doing that in a particularly good fashion. So if you can see the graph on the side here with the red and blue lines, this is from a study that looked at self-sampling, self-reporting. Oh, what's happened there? Have you lost my slides?
Yes, we've lost your slides.
Oh dear, just pressed on the wrong thing. Let's try this again.
I was just trying to unpick the graph in my mind as well.
Sorry, guys, I don't know what I just pressed there. Let me try sharing again. Share my screen. How's that? Can you see that now?
I can see that. Can everyone else? If you put your thumbs up. Brilliant. Thank you, Jen.
Sorry about that. Okay, so coming back to this graph, this is self-reported rates of sort of questions asked about the different sort of challenges that people were experiencing as they were getting older. And you can see, just very simply speaking, the blue is people who do not have HIV and the red is people who do have HIV. So if you're looking at scores, by and large, people with HIV are doing less well. What's wrong today? Okay, there you go. And the question that's often asked is, does HIV age you faster, or is it that you is it a sort of accelerated or an accentuated aging process? And of course, the answer is probably a bit of both. So by accentuated aging, we mean that people have the same problem as their age-matched counterparts, but it happens more frequently. And by accelerated, we mean that some of the conditions that we expect when people age happen at an earlier age. So it's a double whammy, really, if you're living with HIV. And the biggest issue really are when we think about the multimorbidities, these are all things that you're all very familiar with: hypertension, diabetes, chronic kidney disease. If you look at people who have had HIV, they, generally speaking, the proportion, the prevalence of these things are much higher in people with HIV than those without. Now, I've used two different terms here. That one is HIV aging and one is HIV aged. And this is important because, of course, if you take the population of people over 50, that's quite heterogeneous in its own right. You'll have some people in that population who've been living with HIV for a very long time, you know, maybe in their early 20s. And these are what we call HIV survivors. You know, they've been there since the early age of AZT in the 1980s. And then there are others who are acquiring HIV in their 50s. So they've not had the virus around for as long. And when you look, if you break up the population and sort of divide it up again in that way as well, it's really important, because if you've had HIV for a long time, you again seem to do worse than the people who are the same ages as you, but also have HIV. And that in itself is also worse than if you don't have HIV at all. Now, it's a bit of a tricky way of explaining that, but I hope that makes sense. And the basic science behind this, my goodness, we have conferences that are entirely devoted to just looking at the biochemical markers and trying to understand the mechanisms behind all of this. Suffice to say, it's a combination of the antiretrovirals, of the virus, of the host's own immunological predispositions, Lots of environmental factors have a play in this. And of course, it's a mixture of all of that, but that's not what I'm going to go into. I'm going to talk a bit more about the clinical side of this. And the best way to portray that, I think, is if you think about somebody who has perinatally acquired HIV. Now, one of my sort of sub-interests is transitional care. So I do the pediatric HIV clinic with Lucy Cliff in pediatrics at the QMC. And I look after the young people when they move to adults. And when I say young people, the oldest person who I look after who has perinatally acquired HIV is in her early 40s now. And biologically speaking, someone who has had HIV for, 20, 30, 40 years is very different to their counterpart. So if you take a 21-year-old with sexually acquired HIV and a 21-year-old with perinatally acquired HIV, the person who had that perinatally acquired HIV has had so much longer duration of HIV infection, and therefore that ART exposure and that viral exposure and the chronic inflammation for a much longer period of time. And what you see there, therefore, is that whilst the life expectancy of someone with HIV, and that's the sort of little triangle there, can you see my pointer on your screen? Yeah, the little triangle there is not that dissimilar to someone who doesn't have HIV. The difference when you look at comorbidity-free life is very, very different. So the young person who's, say, 21 years old, the expectancy that they have in terms of comorbidity-free life is very different to if they didn't have HIV. So this kind of segues really into cardiovascular disease, and I'll just point out here in this fairly old piece of work now that you can see that even if you're 21 years old and you're living with HIV, you have a fourfold increase in something as blatant as a myocardial infarction compared to someone who is HIV negative. And obviously, when you start to look at the age where you have more MIs anyway, you do see this big difference in people with or without HIV. You know why people get cardiovascular disease. This is your bread and butter. You know about all of these risk factors, really. But I will just throw in there that there are additional risk factors in our cohort because they have the inflammation related to HIV. Even if they're extremely well controlled on their medication, there's the impact of various different antiretrovirals and also the virus itself. And if we look more closely at some of these metabolic risk factors, the health behaviors is one component. We know that about 25 to 30% of our HIV cohort are still smoking tobacco. We know that there's a lot more childhood, particularly, but lifetime trauma. And we know that particularly childhood trauma is associated with increased cardiovascular risk. There's more poverty, there's more socioeconomic deprivation. There's no point talking to someone about healthy eating if they're having to rely on, food banks for their food, for example. Or you can have that discussion, but you have to be very conscious of what their life is like, essentially. So there's a lot of social factors, that goes without saying. But the chronic inflammation related to HIV, the adipose tissue dysfunction related to HIV, the dyslipidemia and the insulin resistance that's inherent in people who have had HIV for a while is also definitely a factor. On top of that, we give them antiretrovirals. Now, some antiretrovirals, like abacavir, are known to increase cardiovascular risk. Others, like darunavir, for example, will cause dyslipidemia. And some of our newest ones that most of the patients that you will come across are on, are well known to cause weight gain. And in some people, that weight gain can be quite significant and lead to significant obesity. So all of these things create a bit of a perfect storm, really, and create some metabolic dysfunction in people with HIV. And it's important to know about these integrases. I'm not expecting you to remember any names, but a lot of the drugs that people are on now, including people coming to the UK from abroad will be on these integrase inhibitors, because the WHO has now sort of the first line treatment for people in resource poor countries involves using this DTG, which is dolutegravir. And you can see there on those lines, there's a different classes of antiretrovirals and integrases, of which dolutegravir is the most commonly used one. You'll see has shown definite trends in weight gain. And so we spend a lot of time talking to people about weight gain in our clinic, which is, of course, a great thing to be able to do, because 20 years ago we were worried about people not putting on enough weight, and now we have the sort of converse of that. So what do? Yeah, we talk to them a lot about it. We look out for fatty liver or MASL or MASLD. We monitor for diabetes. We do their blood pressures in clinic all the time. We refer to our dietetics department. So we've got a really fantastic HIV dietitian who his workload has about tripled in the last few years. We also have a joint liver clinic, an HIV liver clinic, which we started up in 2017. I do that with someone called Rob Scott, who's one of the hepatologists. We started that up to treat all our hep C co-infected individuals, and we've sort of quickly done that, and the clinic has now become a fatty liver clinic, essentially. So we try and manage that. We try and signpost for smoking cessation and support some of the social factors, but we need primary care to join us with this, really. So optimizing blood sugar control, antihypertensives if appropriate, weight management, diabetes prevention programs that you may have access to. GLP-1 receptor agonists, I know, are a hot topic. I don't know if any of you have started prescribing them yet. I certainly have a number of patients who are obtaining Mounjaro privately, and there is a lot of safety data now saying that it's fine for people with HIV to use these. There are a couple of things we need to be conscious of in terms of how it suppresses appetite and what that might mean for certain antivirals. But with the right support, it's absolutely fine for people to use them if they meet the criteria for requiring them. And several of our patients, lots of our patients have BMIs over 40 now. So we are hoping that we will have support from you all in prescribing that when you yourselves can get your hands on them. The other area is dyslipidemia management. So I wasn't going to talk about trials a lot in this talk, but this one is one that I think you do need to know about, because you'll be receiving letters from us where we will be sort of talking about the Reprieve trial. And it's very rare for a single trial to make such a massive impact in terms of treatment protocols across the world, really, but this is one of them. So this was a huge trial that was done mostly in the States, but 7,700 individuals living with HIV, and they were randomized to either receiving or a pitavastatin 4 milligrams or a placebo. Now, these were individuals who did not have a particularly high cardiovascular risk, according to the scoring charts that they use, which is the American Heart Association one. So we use Q risk 3, but they're fairly similar, and you can have long discussions about what the best cardiovascular risk assessment score is. But they essentially took people who had low or moderate cardiovascular disease risk, people who didn't have particularly high LDL cholesterol levels, and either gave them a statin or gave them placebo. And the study was stopped early because they found that there was a 35% reduction in major adverse cardiovascular events, so heart attacks and strokes, significant events, essentially, after just 5 years of follow-up. That's quite profound, really, and that led to, this was about a year ago, that led to first the British HIV Association changing their guidance. Subsequently, the American and the European guidelines have all changed. Why was this seen? Well, it wasn't enough to explain this by just saying this is a cholesterol lowering effect. The hypothesis is that particularly in people with HIV who have that increased level of chronic inflammation, the statins also play an immunomodulatory role. And I think that is probably the key to it, really. So this is just a diagram showing a bit more from that study. You'll see that, significant difference in terms of cardiac events. There was a slightly higher rate of diabetes in people on a statin, but I think that's known about anyway. And even accounting for that, there was still this reduction in cardiovascular disease. It was otherwise seen to be fairly safe without any significant other side effects, really, with just a few sort of mild muscle-related symptoms. So, as I said, this led to quite significant change in guidance, and now everyone over the age of 40 in our cohort is having a discussion around statins. And certainly if their Q risk 3 is greater than 5%, we're encouraging them to start a statin. So this is obviously something that's a little bit different for primary care. So we might be contacting you saying, please could you start atorvastatin? And we're using atorvastatin 20 milligrams because we don't have pitavastatin, although that will become first line as soon as we do have it. I think it's imminent. You may know more. I don't know if you've already got it, but so this is a little bit unusual, I think, for primary care, and this is something that we do liaise with you on. We usually put this link that you can see at the bottom of the slide, which is the guidance, into our clinic letters. But one of the questions that we keep on sort of struggling with is who should be prescribing the statin? So on one hand, it's very sort of, I would imagine this is bread and butter stuff, statin prescription in the community. However, it's not urgent, so the patient doesn't need to start it within a few weeks. They do have time to make an appointment in primary care. And also, one of my colleagues who started off just prescribing it, at least prescribing the first month's worth in clinic, did got a couple of sort of letters saying, well, why have you done this? You've started something and you're asking us to continue it. So the couple of GPs that he worked with weren't particularly happy about it. So the question is, I think most of us will write to primary care and say, please, could you start this according to the guidelines? This is why, this is the drug, if there are any drug interactions. Most of the time there isn't. If there is a drug interaction to be aware of, we will give some guidance around that, and hopefully also convey some of the baseline bloods, because we're usually doing bloods in clinic anyway. When we see everyone every 6 months, they tend to have a needle stuck in them. So we try and bring that all together. But it's hard for us to know what we should be doing. And I was hoping that if there was a big audience here, I might do a Slido and try and get a feel for what the local prescribers think. But you can maybe tell me your thoughts towards the end. So let's move on to bone health. How am I doing for time? Good. Okay. So similar to cardiovascular disease, there is a higher rate of osteopenia and osteoporosis in people with HIV. Tends to happen at a slightly earlier age. We do FRAX risks for everyone over the age of 50, and you'll see that we order DEXA scans quite often if someone's risk is borderline. We actively screen and treat for vitamin D insufficiency and deficiency. We talk about risk factors. We change people's antiretrovirals. So there's particularly a drug called tenofovir disoproxil, which is known to be bone and renally toxic is a strong word, but is not great for your bones or for your kidneys. But the kidney and bone friendly version, which is tenofovir alafenamide, is restricted in terms of commissioning. So unless somebody does have certain risk factors, we can't automatically prescribe the tenofovir alafenamide. But if somebody did have osteopenia, for example, on their DEXA scan, that would be a good reason for us to make a switch. Similarly, we think about other things like, Depo-Provera, for example, if it's a woman and they're on that for contraception. Which then segues on to the menopause, is the whistle stop bit of it. So again, the menopause is an area which is slightly different in people living with HIV. There's the chronic inflammation, of course, as well as the slightly higher rates of ovarian dysfunction that we see with people living with HIV, and particularly if they've been quite immunosuppressed previously with opportunistic infections, they may have a slightly earlier menopause. When we think about the menopause, there's a huge, again, study that I sort of make you aware of called the PRIME study. This is a study of 1,500 women living with HIV in England, so across 21 clinics in England, all aged 45 to 60. And this is a sort of prospective cohort that we get lots and lots of data from. So this is just one slide, just talking about the prevalence of menopausal symptoms. And you can see there that really that the prevalence of symptoms are pretty high in this group, and the median age of this group is 49. So a fairly sort of an age that's very close to the menopause, essentially. The difficulty here, though, of course, is that when you're also living with HIV, it's not always easy to know whether the symptoms are related to the menopause or whether they are related to something else. Take sleep disturbance, for example. I often have people saying, "Oh, I'm really struggling with my sleep." But is it the tablets? Is it the antiretrovirals, or is it something else? Is it depression and anxiety? Much higher rates of depression and anxiety in people who live with HIV compared to the general population. And then if on top of that, you're also perimenopausal, which one is it? So it can get a little bit murky in terms of working out exactly what the causes are. But it's important, I think, to just highlight how prevalent these symptoms are. And it's particularly important because a lot of these women are Black African, and culturally, many will not complain of these symptoms. So it's important to ask if you get an inkling that there might be some issues, somebody maybe comes and tells you that they've had a bit of, that maybe have urinary tract symptoms, it's worth asking about all of these other things. And this is data from studies prior to PRIME, again, showing the increase in vasomotor symptoms and psychological symptoms. Previous studies didn't show much of a difference in cognition or sexual function compared to people who were not living with HIV. So I think maybe the jury's still out a little bit on those, but we do know from other studies as well that there is an increased risk of osteoporosis and increased cardiovascular risk with the combination of the estrogen depletion and aging and HIV. This is a really useful tool, I think. This is the British Menopause Society's 2-page little guidance on HIV and the menopause for primary care. You may find that useful if you look after people and you chat to people about the menopause and maybe manage their HRT. We also have a specific HIV and menopause service at NUH that one of my colleagues, Manjula Pami, does. And so she will see people and she will initiate HRT if appropriate. And she also has the opportunity there to switch antiretrovirals if necessary in terms of drug interactions. So whistle stop now through a couple of other little things. So just to mention cognitive function, there is something called HIV-associated neurocognitive disorders. This is something that essentially is related to chronic inflammation, but also is particularly prevalent in people who had very low CD4 counts. So this phenomenon of late diagnosis where people are found to be positive when their immune systems have been quite depleted. And here again, we may need to change their antiretrovirals around to make sure that what they're on penetrates through the blood-brain barrier as well as possible. But also it's sometimes a little bit tricky because, again, when people are getting older and they have cardiovascular disease and they have diabetes and hypertension, they may be having, purely age-related cognitive decline as well. We should be doing more screening in our service. We're not really doing as much as we should at the moment, but we do ask about cognitive function, and we may well reach out to you if we have concerns for further referral. And actually a lot of it is sometimes around the sort of social support that people need at home. As I said, depression and anxiety, 1 in 3 people living with HIV has diagnosed depression and anxiety. And that's across the ages, actually. But as you can imagine, as people get older, the risk is quite significant. I don't think I can say it necessarily becomes greater, but there's a lot of loneliness in the cohort. If you think about some of the people who are getting older, they've experienced quite a lot of grief and loss in their lives, particularly around HIV. And there's also the added impact of poverty, of course. So we do have a counsellor. We do screen for depression and anxiety in clinic. We may then reach out to you around antidepressant prescriptions if it's suitable. We also really have a big emphasis on peer support, and we've recently had a little bit more funding to really support the peer support element of our service, which is known as Thrive, and that's the link to them just down there. Renal function deteriorates with age anyway, but it's again a slightly added risk if you're living with HIV. There is something called HIV-associated nephropathy, which is again usually seen at lower CD4 counts, but some of our antiretrovirals are not particularly kidney friendly and can cause additional insult. That are driven by oncogenic viruses that have a higher prevalence in people with HIV. But you might be surprised, I don't know if you knew that, lung cancer is more prevalent in people with HIV as well. So important to just be aware of that and be, if somebody presents with a cough, etc., you'd go through the usual processes, but just have that slightly higher index of suspicion. In terms of screening programs, bowel and breast cancer screening, you do that just as per general population. Cervical screening should be taking place on an annual basis for any woman living with HIV who has a cervix. Finally, we reach polypharmacy. This is a problem for everybody aging anyway, and it gets slightly more complicated if you're dealing with medication with a lot of drug interactions. So just to remind you, when you're talking about drug interactions, it's a sort of two-way street. So if your antiretroviral drug, the antiretroviral drug could impact on the co-medication and either increase its levels and cause adverse effects, or could reduce its levels. And similarly, a concurrent medication, something else that's being prescribed, can also impact on the antiretroviral and similarly increase side effects, or sometimes extremely worryingly stop it from working. And I'd say in the last year, the commonest sort of issues we've had have been with triamcinolone injections. For people with protease inhibitors, we've had at least 2 people in the last 5 years I could think of who've had iatrogenic Cushing's because of it. And with steroids, you have to also be careful with things like nasal sprays, like mometasone nasal spray is a problem with some of the antiretrovirals like darunavir, ritonavir, atazanavir. These are not that commonly used, but occasionally they are. So you just have to be conscious of what they're on if you're prescribing this. And similarly, things like, what am I thinking of? Foster, it doesn't have to be a tablet is what I'm saying. It could be an injection. It could be, strong topical steroids for skin conditions. You just have to check. Similarly, proton pump inhibitors, I think, they get prescribed left, right, and center, don't they? And there are 2 particular antiretrovirals which require an acid medium for absorption. So we have had people given a proton pump inhibitor, and because they don't see us for 6 months, we don't know about it. And when they come in, they have resistance because they've their rilpivirine level has dropped so low that they've essentially not had enough therapy for the last 6 months, even though they've been taking their tablets religiously. Another issue that causes us a bit of a headache are over-the-counter calcium and iron supplements, particularly with integrase inhibitors, which, as I said earlier, is the sort of drug that's most commonly used. These, if they're taken at the same time, can cause they have a chelating effect, and they can basically bind to these drugs so that they're not well absorbed. So if they are taking any multivitamins, we always tell them to take them at the opposite end of the day. And the reason I'm just throwing this in is, obviously we worry about the impact of any of these drug interactions on that person's health itself. But at a time where U equals U we tell all our patients, if you are taking your tablets every single day and you're undetectable, then you cannot pass HIV on to someone else. Even with condomless sex, you really don't have to worry about it. On one hand, that has been absolutely liberating, but on the other hand, it does mean that we have to be really careful as healthcare professionals not to do something to scupper that, because if they are not aware that they're taking something that is going to reduce their antiretroviral levels and therefore make them viremic again, it has an impact not only on their own health, but also potentially they could pass that HIV virus on to someone else. Just for the pharmacists in the audience, here are some of the commonest prescribed medications that, especially in people getting older, and just sort of drug interactions in terms of classes where you need to be careful. I've mentioned the steroids. When it comes to statins, again, I don't think anyone really uses simvastatin anymore. That's a big issue for us. Atorvastatin is very manageable. If you're on a protease inhibitor, we'll advise you to start it at 10 milligrams and not to go beyond 20. But for people who are, for example, on an integrase, there's no interaction there at all. Similarly, people buying Viagra over the internet, if they're on a protease inhibitor, we need to give them quite a lot of advice around how to actually do that safely.